Thank you, everybody. Appreciate you all being here for such an important topic. My name is Kristen Kelly, and I'm the Director of Infection Prevention and Epidemiology for IU Health Academic Health Center. And the last month of my life has been devoted to nothing but COVID. So I'm excited to share some learnings with you for the OB and breastfeeding world. So let's get started. So our agenda today will encompass the following items. What do we know about COVID-19? How is the disease spread? What are some of the implications for COVID and pregnancy? Let's talk a little bit about human milk and the implications for breastfeeding and pumping. And then we'll cover some of the basics related to breast pumps and cleaning your equipment and preventing the spread of this disease. A couple caveats. The global picture of COVID-19 is a fluid and evolving situation. This is part of the complexity of trying to contain this virus because new information is changing daily. We had no information on this virus as of last year, and so studies are coming out by the day, and we are rapidly trying to synthesize this information and formulate strategies. So please note that the information in this webinar could change as CDC and WHO guidance changes, and that is happening daily. We do know that this COVID-19 is affecting all ages of the population, both at the extreme ends of the spectrum, but also in the middle. So a lot has been published about this in immunocompromised patients. But really, this is an outbreak of respiratory diseases caused by coronavirus. It is a large family of viruses that are common in people and in many different species of animal. You've heard multiple terms for this: SARS-CoV-2, coronavirus, COVID-19. It is a virus that's in the family of MERS-CoV, which has occurred in Saudi Arabia. It's also linked to the other SARS viruses, so it's in that family. It did originate, as we know, out of Wuhan, China, so that is the piece that we know. The clinical picture is not fully known, and the respiratory symptoms can include fever between 2 to 14 days after exposure, with an average of 5 days. So if you think about the incubation period, day 1 is when you were likely around someone or something that had the virus contaminated. And then we call it the incubation period because it likes to sit and basically incubate in your body until you get signs or symptoms. So that can occur between 2 to 14 days. So that causes complexity if you can be exposed 2 weeks ago and you don't present symptoms for up to 2 weeks later. But the average is around 5 days. About 90% of people will have fever, and then roughly around 60% will have cough, shortness of breath, myalgia. 20% or less will actually present initially with diarrhea or upset stomach. So there's a lot of different factors. But it's complex because not all fever is going to be COVID. We still have roughly around 5 different respiratory pathogens that are in circulation right now. So if you are in your hospital and someone gets a fever, you want to assess them clinically, but you don't want to say every fever is a COVID fever because we have so many other things that are spreading. We have influenza A, H1N1 influenza, metapneumovirus, so a lot of different viruses right now, which just adds to the complexity of the situation. So there are a lot of steps to prevent illness. If we go all the way back to where this started, there are linkages with this virus and being found in Wuhan, China. And that is interesting because there was a animal market that was selling some exotic animals, and this SARS-CoV is actually linked back to bats, and sometimes they will sell this in this animal market in China, which then they think spread to a pangolin, which is a really neat animal. You'll want to Google that. They're kind of cute in a weird way. And that pangolin was sold in that market, and then they think that it aerosolized to humans. So as part of the cultural practice in China, they will actually slaughter those animals in front of people, which can aerosolize some of the virus. And then it was a cluster in that animal market that then set off the chain of events that occurred now. China has since banned that practice, but that is where this really started. So some of the prevention tips, we'll cover this now and then in detail moving forward, but there are a lot of things you can do to prevent COVID. I think the big thing we're all waiting for is a vaccine. There is currently no vaccine that can prevent COVID-19, but there are many that are in progress. So we're really encouraged about that, and we see that as the end game that will help us to stop the spread of this. Other essential practices to prevent this, both in the hospital and in the community, are to avoid being exposed to the virus. So you see across the country, they're doing a lot to contain the spread by staying home if you're sick, mandatory governor's orders, which are happening in some of the states to avoid all non-essential travel. That is key, because what that's going to do for us working in healthcare is it's going to stop the spread or the pace of the spread. So if we can prevent the fast pace of the spread from occurring, we can give our hospitals additional time to prepare for the surge of patients that's likely going to be occurring, and it has already started to occur in many of our sites. The virus is thought to spread mainly person to person. It is what's known in epidemiology as a droplet organism. So you will see the hospitals are putting the patients in droplet and contact isolation. They're also using airborne and contact isolation. We are using a mix at our hospital, and I know there's a variation, but in your hospital you will see one of the two. What we know about this virus is that it can aerosolize within 3 to 6 feet. So if you are around someone that is coughing or speaking or aerosolizing in any way, that virus will likely spread in the air around 3 to 6 feet, and then gravity will take hold and drop it to the floor. When it drops to the floor or drops to a table, that's how you can spread it through contact. So you can either inhale something, a respiratory droplet from someone that you're around, if they coughed in your face or they coughed around you. You can touch a surface that's been contaminated with this virus and then touch your eyes or touch your mouth. So there's multiple ways, but they're thinking the two primary are through the air and through the land. So touching a surface contaminated with it, or coming in contact with air and breathing that in. These droplets can land in the nose, the mouth, or the eyes of anyone, and then they can be inhaled in through the lungs. But ultimately, the best advice is to stay home, both if you're healthy and you can, or if you are sick, quarantine as soon as possible. Now, for us that work in healthcare, I call us the healthcare heroes. You are going into work at this time. And so I think it's important to continue to try to do respiratory isolation, social distancing in the hospital and outside. So if you have a family member that's sick, try to quarantine them in your home. If you are a healthcare worker, do not come to work ill at all. If you are around someone, try to encourage them to go home and to isolate as much as possible. So those are some key things. Additional steps to prevent illness we call this respiratory hygiene. So if you are around someone that coughs or sneezes, you want to cover your mouth and your nose with a tissue when you cough or you sneeze. That prevents the aerosolization from occurring. You block it, you stop it from getting into the air. We are also doing a really good job of masking patients. Many hospitals have stopped visitors from coming in the door. If they do come in the door and they're symptomatic, we try to mask them as soon as possible. That surgical mask will prevent aerosolization from occurring. So throw those tissues, if they do use a tissue, into a trash can ASAP. And then you want to wash your hands with soap and water for at least 20 seconds or using hand sanitizer. There's been a lot of publications in the news about hand sanitizers out, hand sanitizers, not at the store. Well, we can't forget that good old soap and water worked just as well. The key, though, is that we really want to use good technique with it. The benefits of hand sanitizer are it's efficient, it's a rapid kill. You can do this while you walk, so you can easily multitask. But if you don't have hand sanitizer available, good old soap and water works well. Just ensure you wash your hands for the right amount of time, so 20 seconds, getting all the areas in between the thumb, the nails, and ensuring a good thorough technique, and that it'll work just fine. So I think just to summarize, because we can't really hit this enough, is no matter where you are, whether you're at home or you're in the hospital, the first step is, if sick, isolate. Or if around someone that's sick, isolate. Social distance. Make sure you put a mask on the patient if they're coming into the hospital's doors. Encourage them to do respiratory etiquette. If someone's coming in to work ill, we want to avoid that practice by ensuring that they, go home or see if we can find someone else to staff for them in the hospital. And if someone's sick in your home, try to dedicate a room for them. Don't let them run all around the house. I know that can be hard with sick children, but try to contain them or dedicate a bathroom. Those are some big things. And then clean as you go. So that's the big piece. Just try to clean as much as possible in your room and also at work. If you are working as a lactation consultant, we're just advising everyone just, wipe down your workstation with the wipes. Let's talk a little bit about COVID-19 and pregnancy. So I think the challenge with COVID-19 is that people are studying this virus as we go. So a lot is being published daily. There's not a lot of literature right now on pregnancy, not a ton of case reports, but a couple studies have come out. And I think we'll know a lot more in 6 months and a year's time when we can really go back and look at the data and get a good understanding. So what we're doing now is using the best available evidence from, national advisory councils. We are using case reports in the literature from anything that's been published, and we're also really using our infection prevention literature, Centers for Disease Control, and WHO. Their guidance is changing daily as we learn more, so sometimes we will put out a practice and then the guidance will change. And this has been frustrating to healthcare workers that want to know what is the best available option for me, and unfortunately guidance is changing and people get nervous because, well, you told me this yesterday and now I'm doing something different. So we're really trying to message to our healthcare providers that we're doing the best that we can in this situation, and we have to be flexible and fluid in a rapidly changing situation. Related to pregnancy, we do not currently know if pregnant women have a greater chance of getting sick from COVID-19 than the rest of the general public at this time. What we do know, though, about pregnancy is that women experience these changes in their body that may increase their risk of some infections. So with other viruses, we see that sometimes women have a higher risk of developing severe illness. So we should extrapolate our learnings from other respiratory ailments to this. Pregnant women should do the same things as the general public to avoid infection. You can help, stop the spread of these by covering your cough, avoiding people who are sick, and then cleaning your hands, often using soap and water, alcohol-based sanitizer. The American College of Obstetricians and Gynecologists did publish a statement that says there appears to be some risk of premature rupture of membranes, preterm delivery, fetal tachycardia, and fetal distress when the infection occurs in the third trimester of pregnancy. Whether COVID-19 increases the risk of miscarriage and stillborn is unknown. Information on the effect of COVID-19 in first and second trimesters is just not available yet. We do know there was an infant born last week in Italy to coronavirus positive mother that did test positive as well, and the infant is recovering well. So I think the best thing we can do is just continue to look at the case reports, stay up to date as best as we can, and I think in the coming months we really will know a lot more than what we have now. So let's talk a little bit about the American College of Obstetricians and Gynecologists. They published a screening tool that is very helpful. We're finding that I think everyone that works in OB should be able to spot COVID or screen for it. That's the most important thing we can do as healthcare providers, is set up really strong screening tools. That can be both at the entrances of our clinics, when the patients register, and when they come in, both for a clinic visit or inpatient admission. Multiple series of redundancies helps to make sure that no one's falling through the cracks here. So what the screening tool is, and there's a link here, is that the first thing you would want to do is assess your patient's symptoms. It's important for multiple reasons. One, we want to make sure that we are isolating and identifying, women with symptoms so we can intervene quickly. And then the second thing is we want to assess their symptoms so we as the healthcare provider can make sure that we're isolating them and not putting ourselves at risk. So if a mom comes in and she has any of the following: fever over 100.4, cough, difficulty breathing, shortness of breath, or the GI symptoms that I mentioned can be found in 20% or less of pregnant women and just the normal population. If they have any of these, then you want to conduct an illness severity assessment. So we want to dig in deeper to really look at this. Let's assess the cough. Let's assess new pain or pressure in that chest. Is she able to keep liquids down? Does she show any signs of dehydration or dizziness? And if there's anything positive related to shortness of breath, this dehydration, the new pressure or chest pain, then we want to move them forward to an elevated risk assessment. And the ACOG recommends that they immediately seek care in the emergency department or equivalent unit that treats pregnant women. Some hospitals are trying to keep folks out of the ED, and they may have some additional triage units they're setting up. It's really going to be facility dependent, so check with your hospital administrators as to what the process is for getting a pregnant woman tested or triaged immediately. If the answer is no on any of those, then we want to look at additional social and clinical risks. Did they have comorbidities? Is there any inability to care for self-arranged follow-up? And if there's anything positive on that second level, they'll be at risk for moderate, and they should be assessed in the ambulatory setting. And then if no on any of those screens and they're low risk, they should continue to be monitored as they were originally. So click on the link for that for additional details, and I'm sure that they'll be updating this clinical guidance as information changes. So in talking a little bit more about providing human milk, which is the best prevention for babies, there was a study published by The Lancet of 9 pregnant women that tested positive for COVID-19. And the clinical records, lab results, and chest CT scans were retrospectively reviewed for the 9 pregnant women with lab-confirmed COVID-19 pneumonia. And the results showed evidence of intrauterine vertical transmission was assessed by testing the presence of this in amniotic fluid, cord blood, and neonatal throat swab samples. Breast milk samples were also collected and tested from patients after the first lactation. 9 live births were recorded. No neonatal asphyxia was observed in newborn babies. All 9 live births had 1-minute APGAR score of 8 to 9 and a 5-minute APGAR score of 9 to 10. Amniotic fluid, cord blood, neonatal throat swab, and breast milk samples from the 6 patients were tested, and all samples tested negative for the virus, which is very encouraging. Findings from the small group of cases suggest that there is currently no evidence for intrauterine infection caused by vertical transmission in women who develop COVID-19 pneumonia in late pregnancy. However, there is no evidence suggesting transplacental transmission based on very limited data, as the analysis of amniotic fluid, cord blood, and neonatal throat swab available from 6 of the 9 patients were found to be negative for SARS-CoV-2. Whether virus shedding occurs vaginally is also not known. So there is a lot, again, I think that we have to understand about this. In addition, there is some data really showing that children may be more asymptomatic shedders, and they may be a source of transmission of COVID-19 in the environment, but they do not actually showcase clinical symptoms like adults do. So I feel like that's encouraging as a parent, that this may affect children, but it may not be as severe as it is affecting adults. So that gives me a little bit of a sigh of relief. But the other downside is that children may become affected with this, mildly asymptomatic, not enough to take to their physician and be a source of spread to their grandparents or their parents. So based off this data, on a personal level, I've been keeping my children away from my grandparents, their grandparents, because we could cohort together and we could socially distance and still see each other, but I would risk that I would be concerned that one of my children right now may be asymptomatic shedders, and I wouldn't want to introduce that into a vulnerable population. So I think more needs to be studied about this disease in children. We're definitely seeing kids test positive, but it's not occurring on the level of adults. And that could be, again, for any number of reasons, that they're asymptomatic shedders and it's mild disease that doesn't even register on parents' radar, or they're just largely not as affected like adults are. But the data is coming forward on this piece. We all know one thing that just does not change no matter what the virus is, that breast milk is the best source of nutrition for most infants. And UNICEF states that considering the benefits of breastfeeding and the insignificant role of breast milk in the transmission of other respiratory viruses, mothers can continue breastfeeding while taking precautions to avoid the spread of the virus to her infant. So let's get a little bit into the specifics about how we can prevent that spread for moms, because we are seeing mothers test positive for this, so we should be prepared in this setting for what could come. So with providing human milk, so when COVID-19 is confirmed in a mom, a couple things are probably going to happen from the hospital perspective, especially for those calling in as lactation consultants, CLCs, IBCLCs, or other OB nurses or postpartum nurses. I think the first thing really from the hospital standpoint is that many hospitals are restricting visitors at this time. Some hospitals are restricting all visitors, and some are restricting some visitors. Some of what I've seen lately is that OB, so moms, pregnant, delivering moms can maybe have up to one essential visitor, which could be that significant other or designated person. And at the most extreme case, it could be 0 visitors, which can be extremely difficult either way it goes, because this is a special time for a delivering mother. Not being able to bring in siblings, grandparents, significant others is hard. It's hard emotionally on the mom, so we should be prepared for that. The other issue that the hospitals are doing is they're limiting caregivers to essential caregivers only. This could look different in many hospital settings. Lactation consultants may be rendered to do care virtually, and that may be tough if it's a hands-on training. It's really going to depend on your hospital's policies, but we should be prepared to deliver education and alternative means, having a game plan available if you have to use an iPad and, coach a mom. If you are allowed in the room of a COVID-19 suspected patient, there will be serious isolation procedures in play. That's going to be one of two things. It's going to be contact and droplet isolation, or it's going to be airborne and contact. So that means, let's talk through droplet and contact. Droplet and contact isolation will be gowns, gloves, really good hand hygiene, surgical mask, well fitted to the face, with eye shield. So if we're going in to do care with the mom, then I think that you're going to be donned in that. There will be very careful procedures for that piece. If you are in an airborne and contact isolation room, the only difference will be an N95 mask. And if you have not been fit tested, your hospital may fit check you. You have to get some training or to watch how to appropriately fit that. No matter what mask you wear, you want to make sure it's fitted to the face, fully sealed. And there's many studies that have shown that surgical masks and N95 with randomized controlled trials showed no significant difference or acquisition of flu. So no matter what mask you wear, again, make sure it's fitted to your face, sealed appropriately, that you have the eye shields on to prevent aerosolization, especially if you're delivering lactation services and you'll be up close to the mom. So that's the big piece, is one, being ready to respond to the isolation changes, and then two, being ready that if you are not listed as an essential caregiver in that room, you may not be allowed in, and you may have to be ready to disseminate training virtually, either through iPad or on the phone, or through some other modality, depending on what your hospital moves forward to implement. If you see the COVID-19 is suspected or confirmed, isolation is the same. It takes a couple days for the lab to come back. It may even take longer if that lab result is being sent to the state. So it depends on if that lab is in-house or not, but whether suspected or confirmed, you do want to just, follow the isolation procedures. Don't rush. Take your time with the PPE, personal protective equipment. Take time putting it on. Take time taking it off. Don't rush. You don't want to rush or skip a step with personal protective equipment. And if in doubt and you're not sure what to do, don't go in the room until you have proper education and you really know how to follow the procedure, so you don't go, barging in there. You want to avoid spreading the virus to the infant. So I think with this piece, if it is confirmed and you know a mom has this, we want to take careful to really use good respiratory precautions with mom and baby. Washing your hands before touching that infant or before pumping. The viral load is going to be higher when the patient's symptomatic. So if we're talking about a mom that has a fever, her viral load is probably going to be very high at that point versus if she had COVID-19 14 days ago and all of her symptoms have resolved. So that gives you a clinical indication of maybe how best to navigate. If the mom is really sick and just not feeling well, high fever, lots of cough, you may want to just take care in this situation to have her pump to a bottle if she's not really feeling well, if we feel like we want to keep a bit of a distance between the baby. We have to handle these very carefully, and we always want to try to preserve the breast milk because at the end of the day, that is going to be the best immune boosting prevention that we can give to the babies, is to make sure that they are at their mom's breast, because mom may be producing antibodies that will, in turn protect that baby over the next week or so. So really, we are a big advocate of trying to preserve skin to skin, preserve mom being with the baby, and preserve the breast milk as much as possible. That is just so important. If mom is breastfeeding, the big thing we can do to prevent the aerosolization is to wear a face mask while breastfeeding. If mom coughs, coughing away from the baby, keeping that surgical mask on snug and avoiding breathing right on the baby are big things. Making sure her hands are clean before and after breastfeeding or before and after pumping, and taking care from that perspective. Many hospitals have a no visitor policy for COVID-19, and so that may mean that dad may or may not be able to come in, or significant other may not be able to come in. And that's when we're just going to have to use a lot of care with the situation related to should the baby stay in the nursery or not. Typically what we would say is that we would want to isolate mom and baby. So if baby has been exposed to a COVID positive mother, we would not be a fan in my hospital of going and putting them in the general nursery, because if the baby does come down with it, then that could cause spread of COVID. There's not been documented cases of this to date, but we would want to isolate the baby to another primary caregiver, maybe in an isolation unit of the nursery, or they could still room in if mom wears a surgical mask. We disinfect things routinely and keep hands clean. It isn't an ideal situation for a new baby to be isolated away from their mother, so we just have to use a lot of good clinical guidance and weigh the risks. So weigh the risks, and this is what we're educating at my hospital is, what are good, better, best options? So if the best option is keeping the baby in the room, maybe isolating the mom with a surgical mask, we're using meticulous hand hygiene to avoid cross-contamination, maybe having the baby outside of 3 to 6 feet from the mom, so if she does cough, they're not in that respiratory zone. And then doing skin to skin, but keeping the face away, for the purposes of breastfeeding. If mom is really sick and just not up for care for the baby, I think they could go into the nursery and isolated from the rest of the population. So do you have a special isolation room the baby could be isolated in? Can we segregate them from the other members of the nursery in a different space or room? Those would be options. Trying to maybe have the dad do some skin to skin if the mom's not feeling well, with a lot of good meticulous efforts. And you'll have to refer to your hospital's policies, because not all hospitals are maybe doing exactly the same thing. So I always want to refer you to your own hospital policies and your own infection preventionists for guidance there. And then again, like the option here, follow your pump cleaning protocols and consider having a well person feed the breast milk to the infant. So again, just remembering the principles that the viral load is going to be highest around the time of heavy symptoms, and then it will drop down, and it will definitely cease about 9 to 14 days after day 1 of positive culture. So viral load will drop pretty significantly. So just to repeat here, CDC guidance, because we can't say it enough, to reduce the risk of transmission of the virus that causes COVID from the mother to the newborn facility should temporarily separate the mother who has COVID from her baby until the transmission-based precautions are discontinued. I think this is hard, and this will be hard for the moms, of course, but use good, better, best judgment. Every clinical situation will be different. It's hard to have hard and fast rules for every situation, because if a mom has a viral load that's high, she has a high fever and is coughing, that's going to be different than a mom that's 14 days post a COVID positive result. And so maybe that mom is improving, she's building some antibodies, and you could maybe just segregate in the room versus someone that's actively sick, and maybe we do need to move her baby into the nursery and isolate and use a healthy caregiver to feed the baby. So I'm not going to give you a black and white on this. I think just continue to think about what's good, better, best option in this scenario, and be very flexible with your approach. Using the best clinical guidance that you have, using your assessment data, and using like the clinical lab data of when it came back. And I think you'll make the right choice for that situation. So, a couple other pieces of mind there, that mothers that intend to breastfeed should breastfeed. We should never advocate for anything other than that at this time. We really want to encourage that breast milk. That is the best prevention for this baby. It's the best protection, and likely they will get some antibodies. I'm sure we will study this in 6 to 12 months to show this in some type of study. But if possible, dedicate a breast pump to that mom for in-room care, wiping it down after she expresses her breast milk, and then practice really good hand hygiene. All parts that come into contact with breast milk should be thoroughly washed, and the entire pump should be disinfected after each use. So regardless of the situation, whether she breastfeeds or she uses a pump, there's multiple modalities we can use for COVID-19 moms. Kit care, the links are here that you can click on for appropriate cleaning. There isn't much different than normal practice. The CDC has identified breast pump kit cleaning techniques for the mother in their home or on the website. It's available in English and Spanish and downloadable from the CDC website. Breast pump collection kits should not be shared between moms unless sterilized in sterile services department. So let's try to dedicate in-room equipment for sure on these scenarios. Here's a little bit more information on exactly how to clean your breast pump kit. So step 1, wash your hands well with soap and water for 20 seconds. Inspect and assemble clean pump kit. Step 2, take apart the breast pump tubing and separate all parts that come in contact with breast milk. Rinse the breast pump parts that come into contact with the breast or breast milk by holding underwater to remove the remaining milk. Do not place the parts in sink to rinse. Clean the pump parts that come into contact with breast or breast milk as soon as possible after pumping. You can clean your pump parts in a dishwasher or by hand in a wash basin, used only for cleaning the pump kit and infant feeding items. Step 3, place the pump parts in a clean wash basin used only for infant feeding items. Do not place the pump parts directly in the sink. Add soap and hot water to the basin. Scrub items according to the pump kit manufacturer guidance. If using a brush, use a clean one that is used only to clean infant feeding items. Rinse by holding items under water or by submerging in fresh water in a separate basin. Air dry thoroughly. Place the pump parts of wash basin and the bottle brush on a clean, unused dish towel or paper towel in area protected from dirt and dust. Do not use a dish towel to rub or pat the items dry. Clean the wash basin and bottle brush and rinse them well and allow them to air dry after each use. Step 4, you can use a clean in the dishwasher. So clean the pump parts in a dishwasher. If they are dishwasher safe, be sure to place the small items into a closed top basket or mesh laundered bag. Add soap and if possible, run the dishwasher using hot water and heated drying cycle. Remove from the dishwasher with clean hands. If items are not completely dry, place items on a clean, unused dish towel or paper towel to air dry thoroughly before storing. Do not use a dish towel to rub or pat items dry. And also just be very careful with dish towels because they can be a source of contamination if you use them between clean and dirty and back to clean and dirty. For extra protection, sanitize the dishwasher. So for extra germ removal, sanitize the pump parts, wash basin, and bottle brush at least once daily after they have been cleaned. Items can be sanitized using steam, boiling water, or dishwasher with a sanitized setting. Sanitizing is especially important if your baby is less than 3 months old, was born prematurely, or has a weakened immune system due to illness or medical treatment. Step 6, store safely. So store items safely until needed. Ensure the clean pump parts, bottle brushes, and wash basins have air dried thoroughly before storing. Items must be completely dry to prevent germs and mold from growing. Store dry items in a clean and protected area. I think this piece is important. And if a mom is COVID positive, I would definitely use the sanitize in the disinfect features until she is 14 days post-positive lab test, just to be safe. I think that is just an extra precaution. It will also help the mom just to feel like she's doing something, to prevent the spread with her baby as well. A statement on multi-user pumps in hospitals. So multi-user pumps are designed so that breast milk can never touch the working parts of the pump that are shared. The only part of the multi-user breast pump that you can safely share is the pump itself. So I think a piece on that, if you are not able to dedicate in-room equipment, this statement will help you feel a little bit better that you can operationalize this process. What we would do, though, is just ensure that we have a really nice process ergonomically set up. So put wipes next to your multi-user pump. Make sure there's a good process for cleaning that down between moms, because it is possible that a mom could be admitted to the labor and delivery unit, postpartum unit, and then not come down with symptoms till a couple days after her admission. So we want to use good prevention no matter what. We know about the moms if they're positive or they're not. So think about that incubation period. If you can be exposed and then brew the virus internally between 2 to 14 days, there could be a lot of moms that are incubating this but haven't shown symptoms yet. So what we're really preaching at our hospital is just use great prevention 24/7 on all moms and all healthcare workers right now. So for those using multi-user pumps, spot check your processes. Make sure they're being cleaned appropriately, disinfected appropriately per hospital policy. because an ounce of prevention is really going to help everybody be safe here. And then with any multi-user product in the hospital or outpatient setting, thorough cleaning and sanitizing according, it eliminates cross-contamination. So let's just spot check all our processes again, like I just mentioned, to make sure it's appropriate. We do know that the PDI, Santa-Claus, the Cavicite, the Quick Clean wipes all have a great claim here. And we want to ensure that we're using the appropriate materials. And then external surfaces should be disinfected. We always say that dry time is kill time, so do not use something while it's still wet after it's been disinfected. We want to let it sit there. We want to let it dry. That dry time actually denatures or kills the virus. So it's in the process of drying that we're actually eradicating that virus or bacteria. So if you use something while it's still wet with the disinfectant, then it likely has not been thoroughly killed appropriately, and we could contaminate others by using it too quick. So I think it's just very important that we take a lot of care from that perspective. So I think in summary, before we take questions, let's just kind of summarize what we've gone through here today. So what we do know is that COVID-19, SARS-CoV, is a respiratory illness that spreads through air and through land, so through contaminated surfaces or coming in contact with someone that is aerosolizing the respiratory virus. 80% of the population will acquire 80% of people that get this will acquire it, and then it'll be just like a flu or a cold. 20% of people will develop more of an acute illness, and then of that, between 3 to 5% will require ICU care. Though we are seeing extremes of age, we are actually seeing all ages be pretty well affected by this, both in the hospital and in the community. Social distancing is going to slow the pace of the spread of this. We all have to do our part to ask our friends and family members to socially distance. That's going to be hard for a new mom at this time who just wants to show off her cute new baby. But at this time, it's really important for everybody's health that we comply with that social distancing. And it's important for us as healthcare workers because that is what's going to slow the pace in the doors. And we need to slow the pace of admissions in our hospital, or the surge will be very intense through our emergency departments. Moms can get this illness, as can children, but right now the case reports are not showing mother to baby spread uniformly, but that can change as people begin to publish more and more becomes known on this virus. Children are seen to be asymptomatic shedders, and they can transmit disease to vulnerable adults. So take this into consideration when you are social distancing, quarantining with your family members. We want to take good care with the moms. What we really want to do is isolate symptomatic people, comply with the right personal protective equipment and isolation orders in-house, and then use really strong prevention techniques of proper hand hygiene, very good disinfecting in the environment, keeping a distance from other healthcare workers where you can, and trying to use alternative means or being prepared that you may be asked to deliver breastfeeding education in a virtual way if you are limited into that COVID positive patient's room. And then lastly, I think, again, an ounce of prevention goes a long way here. We have to stay focused on really strong prevention mechanisms. But breastfeeding and breast milk is the #1 way we can prevent and help our babies to have really good immunity and good health. So we want to preserve breastfeeding in all instances. So if a mom's too sick to pump, or moms too sick to breastfeed, encourage pumping, having a well person feed the baby. And that may be important around the symptomatic time period when the mom is shedding more of the virus. Viral shed goes down between 9 to 14 days. And so 14 days after day 1 being the first day of symptoms, about 2 weeks out, her viral shedding will go down to very little. So she'll want to use really good care with the cleaning of her pumps and equipment. So with that, we'll take some questions.
Okay, thank you, Kristen, for that great information. We do have about 9 minutes for questions, and we do have them coming in. Just a couple quick things. You can send in your questions via the chat function. The ones that we don't get to, we will have Kristen answer, and we will get those answers out to you. And certificates should be available on your accounts hopefully by Friday. So with that, Kristen, the first question that we're going to go with is, do we know how long the virus remains on different surfaces like clothing versus cardboard?
Yeah, I think there's some interesting opinions on this. I've seen a couple studies that say on average it can last up to a few hours to anywhere up to a couple days. And so I do think that more will become known on this. Viruses typically need a human to survive into. They need some cell to reproduce. But with this one, best case a couple hours, worst case a couple days, and I'm seeing it can vary depending on the type of the surface, whether it's like plastic or glass. Knowing this, my intervention advice is still the same. Disinfect every high-touch surface. The CDC published a definition of high-touch surfaces. It's exactly what it says. It's surfaces that are touched frequently. Those are your doorknobs, your elevator buttons, your light switches, your bedside tables, the patient's TV remote, handles of the sides of the beds. So getting those disinfected is key. And assume that it can live on surfaces for a couple days till we know better.
Okay. The next question is, if mom is infected, do you then send the newborn baby home with the infected mom when she is ready to go home, or do you keep the baby longer?
So I think that'll depend on the clinical situation and what's going on with the mom and baby. So I defer to doctor's judgment on this. But what I do think we're seeing is that we're trying to get people home as soon as able. So if mom is positive and she has no underlying or worsening respiratory symptoms, nor does baby, then she should be able to go home, and that's what we're advocating for. But obviously, if the clinical syndrome worsens, we're seeing sometimes in these acute illnesses very, very fast respiratory decompensation, and they're advocating for early intubation. So this can come upon really quickly, very, very fast pneumonias. But if mom's respiratory illnesses are good, O2 stats great, able to breathe, signs and symptoms warrant it, then she should be able to go home with her baby for sure.
Okay. The next question is, what considerations should milk labs and kitchens be taking?
I might need some clarification on kitchens, but I think from milk lab perspective, we should continue to treat this like we do any other, dangerous pathogen, where really good safe handling, and I think milk labs have some of the best processes around, very, very strict protocols for the handling of milk, making sure we're dating the milk appropriately. And so from that perspective, there's been no guidance that I can see for any different handling with the milk labs. So the kitchen question, I might need some clarification as to what we mean by kitchen, like in-home kitchen.
Okay. If whoever sent that question, if they can send a clarification, we'll try to get to that remaining question. But the next question is Cavicide enough to clean the breast pump at this time? Does it clean coronavirus?
So great question. I believe the Cavicide is. We want to look at on the back of all the bottles for the kill claim. We've been looking for, sometimes I think it's like coronavirus kill claim on the back, because there is a general coronavirus that circulates as well. But my understanding is the Cavicide is good for my recollection. But I would refer to your hospital's policies because they should be issuing some guidance specifically related to their cleaner. So I do not want to trump your in-hospital policies or statements.
Okay. The next question is, does the mother need to clean her breast before breastfeeding?
That is an excellent question, and I think it's a catch-22 because sometimes if we clean the breast or we use like a CHG disinfectant on it, we can wipe out the good and bad bacteria, which could mean they could be recolonized with bad bacteria over the course of time. I've seen nothing advocating for that as an intervention. I think that really it should be about that clean hands and covering the mouth. So the source of contamination from this virus is going to come either by contamination of the mom breathing or coughing on the baby, or from the mom touching a viral load on a surface, or by coughing into her hands and then going and touching her baby's head or breast. So always think about this in terms of what can I do to interrupt the chain of infection. She can wear a surgical mask to interrupt the aerosolization of what she coughs, or she can clean her hands if they're contaminated before touching. And then that way, in theory, if we keep the chest covered, we shouldn't be contaminating the skin too much there. So interrupt the chain of infection. Hand hygiene and masking are always going to be the best options before, cleaning a breast.
Okay. The next question is, will the baby need to be bathed prior to any skin-to-skin?
No, I would not advocate for any difference in your hospital policies based on bathing at this time. I think we want to use clean linens, so you can always put, if mom's sheets haven't been changed, let's say in 24 hours, you could always lay the baby on a clean sheet on the mom and then have the baby nurse, so that you're kind of always trying to break up dirty to clean. So I would look at some of those smart strategies.
Okay. It looks like we've only got a couple more minutes, and we have got many questions that are still coming in. So what I will do is leave the webinar going for a couple minutes and collect the rest of the questions. And I'll send those over to you, Kristen, for you to answer as time permits. We all know that you're very busy during this time handling things. But once again, everyone, the certificates should be available later this week by logging into your account. And we appreciate you taking the time out of your busy schedule right now, Kristen, to deliver this valuable information to everyone that's on the call. And I hope everyone stays healthy and is safe and enjoys the rest of your afternoon. Thank you, everyone.
Thank you.